I right, okay, so all right, are you all seeing my screen share? Yes, no, maybe.
Yes, we can see.
Right, good. Okay, so of course, no cheating as in any exam. So myopia is the most common ocular disorder worldwide. Now, that is actually not a clear statement, but it really should be. If the research is done, you find that there are more people with myopia than any other eye condition. And the reason not much research has been done about it in the past is that we didn't used to think of myopia in the same way that we did now. Myopia used to be a condition that we just treated with spectacles, contact lenses, and told the patient, well, there's not much that can be done. So the beginnings of discussion about myopia started with Aristotle, 350 BC, and the term morphs or turned into myopia over time. Myen means to close and opt the eye. And what happened is Aristotle actually made the link between bulging eyes, frequent blinking, squeezing of the eyelids, and the person being able to read close up and with micrography. Boerhaave in the 1720 mentioned excessive length of the eye as a cause of myopia. And Purkinje of the famous Purkinje images was also myopic. He had read in an anonymous text that putting a bag containing iron filings on the eye reduced myopia due to its magnetic force. He, however, thought it worked due to the weight. So at night, he put a leather pouch with about ½ pound of weight on the eye and could see less, could read less the next day, but see better far away for a few hours the next morning. According to a recent article in Clinical and Experimental Optometry from 2019, we face an epidemic of myopia as its global prevalence continues to rise at alarming rates. So it is predicted that half the world's population will be myopic by 2050 and 10% will be highly myopic. Most myopia is associated with excessive elongation of the eye that stretches the retina and the choroid, which increases the risk of ocular pathologies. Sight-threatening complications of myopia can include things like myopic macular degeneration, macular hemorrhage, cataract, glaucoma, retinal breaks, retinal detachment, and of course, during cataract surgery, there is a higher risk of developing complications. Pathologic myopia usually presents before the age of 6. So any child who is found to be myopic before the age of 6, you must consider either they are presently myopic or will become pathologically myopic as they get older. They have abnormal extreme axial length, and it may not progress as in that age, but often it does. School age myopia, which is the typical sort of myopia we would tend to see, 6 to 18 years old. This is a progressive condition and stabilizes late in the teens, early 20s. It's often associated with a higher IQ, more time spent reading, less sunlight exposure, more time spent in education, and more common in urban as opposed to rural settings. There is, of course, the subtype of the adult onset myopia, which is less common, 20 to 40, and they often have focusing abnormalities. They may have corneal abnormalities. They may be in an occupation that is near vision dominated, and it can be cataract induced. I have seen a patient fairly recently with progressive myopia after the age of 30, and she did have cataracts. But myopia in all groups is usually due to progression to an elongation of the eyeball. The eyeball becomes egg-shaped, and to control or prevent worsening of myopia, the rate of elongation must be slowed. The earlier the onset, the longer and faster its progression. There are some determinants of myopia that we are aware of. They are both environmental and genetic determinants. The environmental factors may trigger the genetic predisposition. As yet, the genetics cannot be altered. One way that has been attempted and still continues to be attempted is use of single vision lenses, certain special types of lenses, which is the aim is to cause active emmetropization and is regulated by optical defocus. And you would have seen some of these lenses are now being touted and sold in the region. Single vision lenses may lead to increased progression and axial elongation. Undercorrection with single vision lenses is advocated by some clinicians, and some research supports this. There are use of bifocals or progressive lenses. It's a relatively small treatment dose effect overall on the order of 0.15 to 0.5 diopters over 18 months to 3 years. The COMET trial, or the correction of myopia evaluation trial, was a multi-center trial, and to show whether this sort of treatment was effective. All the treatment effects in this situation occurred in the first year of treatment. A similar study to COMET was conducted in Japan, and it suggested that early treatment may work better than single vision lenses in 6 to 12-year-olds. Contact lenses have been used to treat as well as try to prevent myopia. The contact lens and myopia progression study, the CLAMP study, there was a statistically significant difference in 3-year progression with RGP lenses, rigid gas permeable lenses versus soft lenses. And again, most of the slowed progression was found in the first year. 3-year axial elongation was not significantly different between groups. Slowed myopia progression was due to corneal flattening. In absence of differences in elongation, they concluded that the RGP lenses should not be prescribed mainly for myopia control. There is a study called the LORIC study, longitudinal orthokeratology research in children. And this is with the use of RGP lenses overnight, and it did slow axial elongation. And over the 2-year period, axial length in the orthokeratology group increased by 0.29 millimeters versus 0.5 millimeters for the control group, which is a significant difference in terms of the statistical significance. And recent randomized trial reported no significant differences in progression between soft lenses and spectacle wearers. So, what has happened? We had a study that came out in 2006, which was an interesting study in many ways. It was a study on which we base a lot of what we do now for children with myopia, and it was a surprising study. It was termed the ATOM-1 study, the Atropine for the treatment of childhood myopia, and it was published in one of our major journals called Ophthalmology, and it actually had surprising results. So this study tested the daily monocular treatment of topical 1% atropine versus saline drops in a cohort of 400 children aged 6 to 12. And they also used different concentration of atropine. The primary outcome measures were the degree of myopic progression by cycloplegic autorefraction, and the change in axial length as measured by ultrasound. Now, remember, this is a 2006 study. These children were followed for 2 years on treatment, and a subsequent year after treatment was stopped. It found, and we had actually known this for a long time, that atropine by itself, 1% atropine, reduced the progression of myopia. And it reduced it in this study by 77% compared to placebo. The reason we had not used atropine regularly prior to this is that 1% atropine can be fairly toxic. And the old joke is, in one bottle of 1% atropine, there's enough atropine in there to kill a small family. There was a clear rebound effect after treatment cessation. Remember, this was a 2-year study. Post-treatment, atropine-treated eye progressed at a significantly higher rate than placebo. And at the end of 3 years, the atropine-treated eyes were less myopic than untreated control. So therefore, despite the post cessation of treatment progression, they were still less short-sighted on average. And therefore, the ATOM-2 study was done in 2012. Going back to the ATOM-1 study, one of the surprising effects of the ATOM-1 study is that they used other concentrations. And one of the concentrations of atropine used in the ATOM-1 study was 0.01%. So they decided in 2012 to do another study. And this is the ATOM-2 study, atropine for the treatment of childhood myopia, safety and efficacy of 0.5, 0.1, and 0.01% doses. And they used varying concentrations of atropine. Now, going back to this study, it was, if you think about it, based on modern standards, a fairly unethical study based on modern standards, but of course things change as we progress. So unethical to treat children participating in the study with a true placebo due to the results of ATOM-1. So if you were treating patients in the ATOM-2 study without atropine, it would be unethical because you know no treatment didn't work. The primary outcome measures, again, were the cycloplegic refraction measured by the autorefractor and the axial length as well. And again, this is, I think in my mind, a little bit forward thinking. And that's actually forward thinking of the people who did this study. But of course, in certain centers, you have access to many different machines that you can use. So, and again, a 2-year study, treatment of the myopia progression over 2 years. So 1% atropine progressed at 0.29 negative diopter, 0.5%, 0.3 diopter, 0.1%, 0.38, and interestingly, 0.01, which was at that time thought to be a placebo or almost a placebo, 0.49. So even at the lowest dose of atropine once at night, there was a significant decrease in the progression compared to placebo. So there, of course, was the follow-up washout period, 1 year post-treatment washout period, with all eyes rebounding and accelerating in their myopia progression compared to when they were on treatment. And eyes treated with the higher concentrations of atropine show the greatest rates of progression, while eyes treated with 0.01% show the slower rate, but still faster than when on treatment. So some of the answers came to us in the LAMP study. which is the study that we mainly use now on our current treatment. So LAMP, or low concentration atropine for myopia progression study. And again, all these were published in the journal Ophthalmology, which is one of the major journals in ophthalmology. It's called the Blue Journal because it had a blue cover. And the LAMP study sought to determine of the low dose atropine, which was the optimum concentration. And they used 0.05% and 0.025% and 0.01%. Now, before the LAMP study, I myself and my team at my office were using atropine at the dose of 0.01% for myopia. And the difference that we had is that it was not a limited treatment, it was a treatment that continued. And we submitted our data, and that can be another lecture at some point in time, but we had good outcomes on the 0.01. However, the LAMP study showed that all concentrations of atropine were well tolerated without any adverse effect on vision-related quality of life. So that's 0.05 to 0.01. And it found that 0.05% atropine was most effective in controlling the spherical equivalent progression and axial length elongation. So at that point in time in 2019, we converted from 0.01 to 0.05, which we use today. So a little bit about the treatment of myopia. Often treatment is statistically but not clinically significant. We go to studies to look at p-values, etc., but does it actually make a difference to the life of the patient? Many of the treatments that we saw before are effective early on, but after the initial months, the treatment effects may increase only minimally or not at all. For those at risk of myopia, we can certainly say that any child who has lived through the pandemic is probably at risk of myopia. We cannot identify with a certainty, though, the at-risk child. We would, and it's an interesting thing, a lot of doctors and optometrists who see children who are, let's say, for example, a plus 0.25, 0.75 diopter prescription, say the child is normal. I would be worried about a child because in my mind, let's say, for example, a 6 or 7 year old with a plus 0.25, 0.75, 1.0 diopter prescription is probably myopic. So refractive errors of less than 0.75 diopter in early school may be an important risk factor for myopia development in the pre-teen and early teen years. So motivation for myopia management. It is difficult to justify the cost and possible side effects of treatment for a child who may never develop myopia. And children and parents might be motivated to comply with treatment if they knew it could stop myopia from developing rather than just slow down progression in already myopic eyes. And I have several children that I have had long discussions with their parents, and we have them on atropine 0.05% at night for the rest of their childhood, and they are not yet myopic. They might be emmetropic, and their axial lengths might be around 23. But based on the family history and also the rate of elongation and of the eye and change in their prescription, we would have started them on treatment, and they tend to be doing well. So the future, treatment options likely to hold promise are correction of spherical of peripheral emmetropic and aberrations by contact lenses worn during the day or by autokeratology, provision of extensive outdoor activity. one of the simplest therapies for retarding myopia may be outdoor activity. And it is a requirement of my clinic and my patients that the children go outside for a duration of up to 3 hours if possible. That was a bit of a challenge during the pandemic. It's less of a challenge as children have returned to school. The prevalence of myopia in children with more outdoor activity hours is lower than in children with fewer hours. Being outdoors is more important than being active, since no association has been reported between indoor sports and myopia. So what do? Well, I offer the parents the use of low-dose atropine 0.05%. I advise on sunlight exposure and outdoor activity. And I have started advising on the use of devices such as phones and small devices. I tend to suggest that they use bigger screens. There's some evidence coming out that it may be a part of the overall management. And I tell the children phones are for phone calls, nothing else. So our protocol is that for our patients, we counsel the patients and the parents. If the child is of the sufficient maturity, they have to be involved in the discussion. I do cycloplegic refraction at the start, and I always repeat the cycloplegic refraction. And some people may say, well, if it's done elsewhere, you should accept it. Just to point out, recently, I have had a discussion with another eye care professional where I think the refraction of the child that was done, that came out as a plus 1.50 was actually plus 10, but that's another discussion. I'm certainly fairly experienced in cycloplegic refractions, having done hundreds while I was in my training. They do get auto refraction at each visit. Fundus photos are done often once a year, but often even more at every visit, based on the patient presentation. We also do axial length measurements at every visit. If there is a need for cycloplegic refraction to be repeated, we will do that. That is usually a case where a child has not attended clinic for a period in time and then return to restart treatment. And of course, there's co-management for those who are interested. So we have some issues that we must consider for the future, because these treatments, if you think about it, 0.05% from 2019 to now is not a long time in the history of any treatment. So we are affecting an entire industry which will have to evolve. That includes things like surgical interventions for myopia, etc. Certainly long-term studies are needed, but we have something that works right now. Of course, education is needed. There often the statement by other professionals, well, I don't believe in that treatment, which is, in my opinion, not evidence-based. So, thank you all very much. Are there any questions? Right, so do you have any questions from anyone?
Hi, Dr. Dass, Rizan here. I have a question.
Yeah, go ahead.
What is the age limit you would say that you would stop doing myopia control?
We have a standard right now that at the age of 18, when the child is no longer a child but an adult, we discuss with them, and we would have to look at their growth in that last year. We will discuss whether or not they want to stop and monitor axial length growth. And if we, based on the patient interaction and based on our clinical findings, we can either stop and see what happens for 3 to 6 months, or continue, and my next cutoff is 21. I have had some patients who have come to me around the age of 18, and they are patients who've had an elongation in their eyes or who have had a worsening of their myopia, and we do put them on treatment until the age of 21. So 18 as the first stop, and then 21 as the second. Okay, I see Anisha Crooks has raised the hand. Anisha?
Yes, hi, good evening. So I have two questions. The first one is, earlier you said that the 1% of atropine is toxic. I believe that's what you said. But
Yes.
during this study, they used it on the patients for 2 years. So did they experience any side effects from the toxicity of it?
They didn't report it. This was in China, and that was one of the issues that people had with that study.
Okay, and the second question is, I know you also said that you would do a cycloplegic refraction,
Yes.
noting that, well, myopia control is mostly within the children, but as you just also stated, you go up to the age of 18. So is it that the cycloplegic refraction is a standard, so although they are 18, do you still do the cycloplegic refraction on them, or would it be a regular refraction?
Well, interestingly enough, it's come to the stage where I can actually look at the axial length of the patient and guesstimate whether their refraction is correct or not. So I will not always do a cycloplegic refraction for the first presentation, but if it doesn't make sense, I would, all right? The younger children, especially those children who are, let's say preteens, you do find a lesser refractive error than is found. On several occasions, I have had people turn up to me wearing myopic corrections and they weren't actually myopic, or they were much less myopic. The older patient, you can see stability in their prescriptions. And oftentimes you can clinically tell if it's a good refraction or not. And we have the backup, of course, of the axial length. So no, not all the time.
Okay, thank you.
Okay. Right. Any other questions? I hope it was clear. Right, well, I think, but if you have any questions, you can always pass them on to me later on. So I will let you.
Sorry, sir. I just had one question. I'm not sure if you covered it. What is the average cost of the atropine treatment?
Well, what we subsidize it a lot because I mean, we decided a long time ago to subsidize it. So when you visit, you certainly pay for your cycloplegic refraction in what we would normally charge. But for the visit, you visit us every 3 months, you pay the visit fee. Normal visit fee is about $500. You don't get charged for refractions, you don't get charged for fundus photo, you don't get charged for axial length or anything. So it's basically the drops themselves, you do pay $300, I think, for the drops. The problem with the drops, they are not commercially available, so we actually do have to mix them up, and we do have some challenges with sourcing the atropine on occasion. So although our drops can last for more than a month in certain instances, depending on where we get it from. So we get the 1% and we dilute it down. So 500 for the visit, 300 for the drops. We tend not to charge for anything else. We actually, interestingly, have submitted our data on these patients that we see to OSRI, the Ophthalmic Society of West Indies, last year. And we found that generally our patients do very well. The ones who actually get new glasses on a regular basis, or the ones who progress, are the ones who don't turn up for their appointments. So we found a good correlation with maintaining your appointments, maintaining your drops, and maintaining your refraction. Okay.
Okay, great. Thank you so much.
Okay. Okay, so I'll leave it to you. If there are any other questions, I'm happy to answer them. Okay.
Okay, great. Thank you so much, Dr. Das, for this presentation. If there are any questions anyone has, you all can put it in the chat and we can answer it at the end of the other speaker's presentation. So now I would like to introduce our second speaker, Dr. Niall Farnon. My apologies. So Dr. Farnon is an Irish-trained optometrist. He has been an optometrist for more than 20 years. He came to Trinidad and Tobago in 2001 after working in both Ireland and England. He joined the University of the West Indies optometry program in 2013 and obtained his doctorate from Aston University in Birmingham, United Kingdom in 2021. His specializations are contact lenses, patient care, dispensing, low vision, and of course, myopia management. So I'd like to welcome Dr. Farnon to present us today.
Thank you, Jomi, and thank you all for being here. So it's great to see so many people here. I really admire TTOSA organizing this webinar because this is an important subject for everybody in the nation. And I hope you all do take some of the points that Dr. Seemongal-Dass discussed and some of this points I'm going to discuss. And there are lots of research that says one thing or the other. And as you would have heard one version with Dr. Seemongal-Dass, and some of the stuff I may say may be a little bit different. And it's important that we make our own decisions because every patient is also different. So what's it all about? Why do we keep hearing about this myopia management? Well, as Dr. Seemongal-Dass says, it's estimated that 50% of the world's population is going to be myopic by 2050, and 10% will be highly myopic. Now, it's not as if this is something new, but a lot more research, particularly in animal models, is telling us about what's happening. And so we're going to discuss the dangers of high myopia. We're going to discuss the myopia management options and patient management, so that when you go back into the office tomorrow or you see your patients in your clinics, you will have these topics. So it all comes down to hyperopic defocus. Now you may say, well, hang on a second, we're dealing with myopia. But hyperopic defocus, which is the top picture, is where the image is actually behind the eye. And then the eye wants to catch up with that. And so that promotes or leads to axial elongation, which is one of the reasons why people are myopic. Now, myopic defocus is where the light is in front of the eye, and that actually slows down eye growth. So again, animal models have shown that the myopic eye tends to have relative peripheral hypermetropia. So basically, even if your patient is -4 at the fovea, they may well be -150 in the periphery. But single vision spherical lenses, particularly spectacles, is going to give -4 diopters in all of it, not just the center, but also the periphery. And so actually that's going to stimulate eye axial elongation. And so this made research to step back and think, hang on, there must be a better way. So when we have our ordinary, particularly spectacle lens, you will find, as I said, you're not getting the image part to be exactly where you want to. The optical correction is the red line, and you can see where both the center image and the peripheral image is on the retina. So that's the holy grail. That's what we want any of these options that we've been discussing to do. Now, some of them do it almost perfectly, and some don't do it at all, as you're about to see. So the visual signals in the periphery have been discovered in animal models to have a stronger influence on eye growth. Now remember, single vision contacts and particularly spectacles do lead to peripheral hyperopia, while center distance multifocal contact lenses, corneal reshaping, and also atropine will result in peripheral myopia and focus on the central light ray, which is again what we want to happen. So what are the risk factors for myopia? The family history, a visual environment, binocular vision, the current prescription of the patient, the age of the patient, the ethnicity of the patient, and also maybe careers. But isn't it just all down to genetics? I mean, my parents were short-sighted, my mother's parents were short-sighted, so surely I'm going to be short-sighted. What are we all worried about? But the challenge is, it's not just genetics, it's also the environment. And genetics can determine how those environmental factors affect eye growth. But given that prediction that in 2050, 50% of the population will be short-sighted, that doesn't make sense for genetics. Genetics cannot account for this change in refractive errors. And you'll see here that as we go along, the genetics element of it is not catching up with what's going to happen. Because even within those 7 years, the average age of Chinese children, the average prescription is moving down to more myopia. Genetics doesn't happen like that. So let's go through some of the factors. Family history. So yes, there's a genetic element of it. The fact that one parent is myopic gives that child 3 times more likely of being myopic. And then if there's 2 parents that are myopic, increases the risk 6-fold. And so, you know, a lot of people think myopia management is very complicated. But even tomorrow, if you see a person who is myopia, you see a person who has a child who does not seem to be with spectacles, you should be discussing, do you know, I mean, there is a risk of little Timmy there becoming myopic. Find out if the other partner was myopic. And there's even more of a risk of becoming myopic. The vision environment, that is the time spent outdoors and the time spent near work, just like Dr. Seemongal-Dass discussed. So it's recommended at least 90 minutes a day should be spent outdoors, and there definitely should not be an excessive amount of near work, which is 3 hours. Now, it's very important that the research shows this does not slow down the rate of progression, but it actually delays the onset of myopia. So if you know someone who has a family history of myopia, but at the moment isn't myopic, sending that child outside or limiting the amount on devices has a strong process of delaying the onset of myopia. But the research that it will stop the progression isn't conclusive. But again, it doesn't help. It doesn't not help sending them outside and stopping them being on the devices. But we would need to be careful to tell parents, oh, we send them outside or we stop the devices. If they're already myopic, there's no conclusive evidence. So yes, get them outside. Yes, get them off the devices. And it's also handy, let's say one child is myopic already and the other isn't, then just let's send everybody out, and that makes it nice and easy. But again, if the child is already myopic, there's no conclusive evidence that going outside and reducing the near amount work will actually slow down the progression. It delays the onset, but if you're already myopic, the cart has gone before the horse. Binocular vision. So again, children with high ACA ratios, particularly those with esophoria, because remember most myopic patients are exophoria, do seem to have an increased risk of myopia in more than 1 year, more than 20 times. Now again, it's important that as we do our eye exams to take this into account. Do our cover test, do our other tests for binocular vision, accommodative lag. So there is this element that what is happening, again, may be linked to excessive near work, is causing the myopia to progress. What's the current prescription? So again, as Dr. Seemongal-Dass said, that if that child of 6 or 7 is in your chair and you do the psychopedic refraction, and it turns out they're half a unit of hypermetropia, a quarter, maybe they're frano, then there's a strong risk that they will become myopic. And this is independent of the vision environment and the family history. So we have the process of emmetization of where the eye wants to become emmetropic. But if your child, 4-year-old, a 5-year-old, a 6-year-old, a 7-year-old, is already heading towards there, then yes, they will progress. So you test a 7-year-old or 6-year-old or +2 after psychoplegic, then they have less risk of becoming myopic. But if you do it and they're already half a diopter of positive, then you need to monitor those a lot more closely. So the younger the younger the patient is and they become myopic, they are going to progress faster. So the age of that patient that's in your chair when they become myopic is going to be an issue. So if we can delay the onset, just like we said, between sending the child outside and decreasing the amount of near work, we can delay the progression and then make sure that patient gets the prescription, not that they were going to get. So for example, if they're -1 at 7, they're going to end up to be -6. If they're -1 at 9, it could be -4. If they're -1 at 11, it could be -3. So the more we can delay the onset, as I said, they're not going to get the prescription that they may have as they were myopic at an early age. The ethnicity of the child, and that's where I agree with Dr. Seemongal-Dass, we as a nation need to do more research, because a lot of this research has been done in China, Singapore, Hong Kong, Taiwan, a lot of these Asian countries. But again, Asian children do appear to progress faster than studies done in European children. And there's even research showing careers. So some third level courses like medicine, law, and engineering have been shown to be able to show the progression of myopia. So again, is that because of the excessive near, as Dr. Seemongal-Dass said about the IQ? Is there this reason, is there that reason? So again, that's something to watch out for. Now I hear a lot of practitioners, ophthalmologists, optometrists, dispensing opticians, teachers, nurses, lots of people out there. Why bother? I'm myopic, my parents were myopic, my granny was myopic. This sounds all too complicated. But you see, we do have an opportunity to reduce the lifelong risk of myopia-associated diseases. And there's numerous options. And no matter where you are practicing, those options are available. And there's many options that you're going to see. Some are more effective than others, but something is better than nothing. And we've been through a pandemic. The World Council of Optometry, with its association with the World Health Organization, has declared this an epidemic. This is happening now. And we have the wonderful opportunity to be part of this. Yes, we see people lose vision with diabetes, lose vision with glaucoma. To get them young, let's see what we can do. So please don't sit in your chair and ask why bother. Get off your chair and ask, what can I do? So, just like Dr. Seemongal-Dass said, no cheating here. But I don't want answers, but you should be able to recognize what these conditions are. And we're going to go through them if you're not too familiar with them. So the first one was a retinal detachment. And again, if nothing I said beforehand wakes you up, I need this to wake you up. I personally am -5 units of short-sightedness. So I am 9 times more likely to have a retinal detachment. Some of my students are -8 diopters of short-sightedness. They're 21 times more likely to get a retinal detachment. God forbid, if anybody's over -15, 88 times more likely to get a retinal detachment. Now you may be going, phew, I'm not that high. Well, look, even someone who's -1 to -3 is 3 times more likely to have a retinal detachment. Now, things like atropine, contact lenses, multifocus, autokeratology have the opportunity to change the progression by almost 50%. So maybe if I had the option of myopia management when I was a child, I would be -250. So instead of having 9 times more likely risk of having a retinal detachment, I would only have 3 times the risk of a retinal detachment. And so this is what we're talking about. And this just isn't pie in the sky. All of you who work in the eye industry, you are going to see retinal detachments. And I have a 9 times more likely of having retinal detachment. If I did have myopia management when I was young, it may have been put down to 3 times. But the fun doesn't end there. The next one was myopic maculopathy. And again, look at me here, I'm 40 times more likely to have this. And even a -1 is 2 times more likely to have this. So I could have cut my risk from 40 down to 2. The next one was cataracts. So again, I'm 3 times more likely to have a cataract of significance. Again, if I had myopia management as a child, it could have been 2 times. And then the last one was glaucoma. And someone who's -6 or more has 14 times more at risk of developing glaucoma. So I hope you see these are nothing to just disperse and think, ah, there go I by the grace of God. Okay, but these are your patients. These are the people you're going to see tomorrow. And then 50% of your patients in 2050 are going to be myopic. So what are the myopia management options? Well, we have non-optical options, education, behavioral changes, and atropine, as Dr. Seemongal-Dass said. So educate our patients, make them aware that there is a thing called myopia management. There is an epidemic on its way, particularly more so with the pandemic, and we've all been stuck indoors for the last 2 years, stuck to our cell phones. Behavioral changes, as we said, get them outside to delay the onset of myopia and get them away from the electronic devices, or even near work, or even textbooks. And atropine, as Dr. Seemongal-Dass said, 50%, very effective. And then the optical options, spectacles and contact lenses. Well, let's talk about what we're trying to do here. And it's very important the patient is always the most important thing. And we should not be giving false hope to patients. Nothing at this moment in time, as Dr. Seemongal-Dass said, genetics, etc., are out there in research, but nothing at this moment in time is telling us that we can stop myopia. Oh, you're at risk of myopia. Here you go. You're not going to get myopia. There's nothing out there. Let's be careful about it. What we're talking about is slowing down the progression. And you know, I love going to these conferences, keeping up to date. Because when I do this lecture for my optometry students every year in October, I used to call it myopia control. And now you'll see the change to myopia management. And that's the beauty of keeping up to date. Because myopia control tries to give this idea we can control myopia. When we can't really control it, all we can do is just manage it. And so there's nothing that you can say to the patient, even that thing, okay, little Timmy is not wearing spectacles at the moment, kick him outside, keep him away from the devices. That's only going to delay the onset. It's not going to stop him becoming myopic. And all these things, atropine and all the other things I'm going to discuss, it's about slowing down the progression. So when to start? So that's a common question. A lot of people think, well, it's too late now, different things. Well, luckily we have a larger window. This is not like amblyopia, lazy eye, where we have to get them at a certain time. And even now, research shows that amblyopia has a much bigger window than existed before. However, the sooner the better. Unless proven otherwise, any myopic child is going to progress. That's the best way to think about it. So again, tomorrow, you have a myopic patient in your chair, and it's 6, 10, 15. They are more than likely progressing. A lot of the evidence is shown, definitely by the age of 9, we should be doing something. Now, this is important because a lot of people are not proactive. So you're here, you're proactive. Dr. Seemongal-Dass is here, he's proactive, I'm here. But there are many people out here who think this whole thing is just fallacy and quackery. And you may find these people in your profession. It's just evidence-based research there. And so definitely, if you're doing 10, 11, 12-year-old, the evidence is there. 6, 7, 8, the evidence is still there, maybe not as much. Now, there's a good question there asked, you know, when do we stop this? So again, research shows that half the people progress until 15, and then 77 normally stop at 18, 90% 21, and then as Dr. Seemongal-Dass said, it is late onset myopia. So it is difficult. But like Dr. Seemongal-Dass said, we measure the progression. When do we see a stop in the progression? Every 3-6 months we do that and see when it is. So the first thing is a full eye exam, a proper history, talk about the family history, age, what they do, etc. The measurement of aided and unaided, the objective and subjective refraction with full cyclopedia, the assessment of the BV status of the patient, and the assessment of the anterior-posterior health. Now, other things like axial length are important, particularly if we're really getting into this. Things like fundus photos are very handy. But you see, I don't want to limit people. I want us all to get onto this public health message, which is why TTOSA has done a fantastic job in Kiyomi in getting this webinar, because we all have to be involved. You see, some people shy away because they don't have an axial length measurement, they don't have fundus photos, and so they think they can't take part. But even if you just speak to the parents, that is myopia management. Let's all get involved in this. Now, the thing about this, you will find lots of research, and for us as optometrists, we do not advocate undercorrecting the patient. Undercorrecting the patient has also been shown to progress the myopia. And so years ago, when I was in university, and ophthalmology and optometrists were advised not to fully correct the patient because the patient wouldn't be able to get used to the spectacles. In optometry, recent times has shown we should never undercorrect the patient. It may help, it may not help, but the strongest evidence shows that it definitely ain't helping the majority of our patients. As Dr. Seemongal-Dass said, we all do need more evidence, but think about that risk of being a -5, 9 times retinal detachment, or the -3, 3 times retinal detachment. So the next thing to think about is that it may increase progression. It definitely doesn't slow down progression, and we wouldn't advise it. And now Dr. Seemongal-Dass has done that as well. But you will find many colleagues who do suggest that it still doesn't make a difference. Oh, the child wouldn't be able to cope from going to -3 to -450. And even, as I said, some parents may have heard that. Now it's our job to change that mindset. So bifocals. So on the left, we have round set bifocals, in the middle E-line, and then we have D-seg bifocals. And this is why I'm happy here that Dr. Seemongal-Dass and myself are here, so we can go through all the different things. So the research that's been done with bifocals is with E-line bifocals or executive bifocals. And this has proven to be very effective, particularly on those with binocular vision problems, as you can see when 3 base-in prism was added. The advantage is the patient still gets great vision, both distant and near. It's a good range of prescriptions that are available in E-line bifocals. And if your patient is not suitable for contact lenses or atropine, well, then it's an option. But again, just like Dr. Seemongal-Dass said, where is the research? Unfortunately, there's only one well-designed study to advocate these E-line bifocals. There's none on round segs and there's none on D-segs because the segments are too small. An E-line bifocal gives you the better segment width. And of course, does that 12-year-old, a 6-year-old want to wear bifocals with that big divided line? And so again, compliance would be a problem. However, it's actually better compliance than with progressive lenses because you don't have the distortion. And it has great success in decreasing myopia progression because, again, the large segment that's there. So if you do find a child that's really at risk of fast progression, it might be an option. But the seg height is near to the pupil without disturbing the distance vision. So we talked about the cosmetics of it. Well, of course, progressive lenses look like single vision lenses. Surely that would be great. But as you can see, almost immediately, the evidence there suggests this is the progression rate of how much we can slow down. It wasn't as good as what we just did with E-line bifocal. Overall, progressive lenses do not perform as well for myopia control as the other options Dr. Seemongal-Dass and myself have spoken about. But if no other options available, well, there you go. Because a small amount of myopia control is better than nothing. So if you take here the average, it's around 20%. Well, look what 20% could do. Well, it hasn't come up, but 20% is a significant control. So let's think 20% of -6 would bring them down to -480. 20% of the -4 would bring them down to 3.2. And if you remember what those risk factors were, well, then any difference is going to make a difference. Now, one of the questions you may have in your mind, well, what is the safe level of myopia? And Dr. Flintoff, who you would have seen done a lot of this research, has stated there is no safe level of myopia. So even those of you who be -2, you're still at risk of all the different things we said. Now, obviously, the -15 and even me, -5, definitely a higher risk. But there is no safe level. So 20% is better than nothing. I don't know where the graph has gone, but there was a graph there. So overall, E-line bifocals and progressives are thought to slow down progression by reducing accommodated demand at near and given that myopic defocus in the superior retina. Continue with this as progression continues. If the progression is changed by 3/4 diopters, you need to go back to something else, and you can go back to single vision when there's no progression for 2 years. Now, again, the beauty of ophthalmology, optometry, dispense, and opticians is that the industry never stays still. And there are triple defocus spectacles, because remember, that's the problem with single vision. It doesn't focus both central and periphery. Now, initially, the results were terrible. Not as good as atropine or contact lenses. So they went back to the drawing board, and now latest research that will be coming out soon is that some of these spectacles with triple defocus optics will get up to 50%, which is almost as good as atropine and autokeratology. So like you're here today, keep an eye on that. 6 months, a year time, you will see the latest data come out. So initially, again, you may hear colleagues who said these are no good, and the initial ones were not exactly the best. But like anything, technology is getting better, and the latest ones that are being trialed at the moment are obtaining significant progression delays and making sure that we're helping our patients. So basically, what I've just said, spectacles are no good. Well, here it is. Yeah, even 20% control can reduce the chance of reaching -6. So if your patient is -1 at 7, and we could get 20% control, then we prevented them hitting -6. Now, if you could get better, like atropine autokeratology, then yeah, excellent. But if we don't do anything, you can see the orange line, then they've gone down to a significant amount. So this is why, guys, no matter where you are in your career, we can all make a difference. So why talk about spectacles? I could have just cut out the last 10 minutes of that. Well, there are some people who are not suited to contact lens wear. There are some people not suited to atropine. And also the contact lens wearers won't be using the contacts all the time, so it is a good idea to have another option. Autokeratology. So let's get on to contact lenses. So autokeratology has been proven to be very successful under myopia control, like anything done properly. We have to be careful of different studies, how they were done, who was done on, etc. But overall, it has been very successful. Autokeratology, for those who may be unaware, is when we put a gas permeable lens on the eye overnight. And just like what Dr. Seemongal-Dass said, when people were putting weights on their eyes with the metal filings, that the lens will actually change the shape of the cornea. And this ball ring pattern that you see here gives that peripheral defocus that I mentioned at the very start. It also gives the advantage that when the child wakes up, takes off the lenses, they can go about their average day with no prescription. So it's a win-win. Now, any of us of a certain prescription can do autokeratology, but again, it won't work, if particularly over the age of 18. So if you know anybody who's under the age of 18 and is not available to do atropine or wants to do autokeratology, never mind being good for vision correction, it's also very good for myopia management. If you're over the age of 18, it's still very good for vision correction, but it won't help your myopia. Now, of course, like anything, just like atropine, just like spectacles, you have to be able to pick the correct patient. So you cannot have someone with significant corneal astigmatism, definitely, more than a diopter. You're going to have a lot of fun pulling your hair out, trying to get it corrected. You don't want a cornea that's too flat. So particularly something like 8.5 millimeters or higher, again, is going to cause you to have sleepless nights. Definitely the prescription range has to be -1 to -6. Some people say -1 to -4 if you want to have an easy life. But this is why, again, if the cart has gone before the horse, you're going to have problems. We need to get them as young as possible. And again, the maturity of the child. Now, some of you in the audience may say, children in contact lenses, oh my God, heresy. But this is where we need to look at the research. There has been proven that many, many days and years of autokeratology in children has not any difference in increase of microbial keratitis as it would be with adults. Think of the risk of retinal detachment. Think of the risk of maculopathy. We have to weigh up things evenly before we start screaming down people doing good things. Why is it so effective? You have a bigger treatment zone than you would with multifocals. And again, I just love why we go to conferences, because actually too big of a treatment zone has now also been proven to be less effective. So we have this nice 4 to 5 millimeters treatment zone. Now, of course, it has its disadvantages. It's also quite expensive. So some people may not be able to do that. So let's talk about multifocal soft contact lenses. So here we're talking about center distance design, which unfortunately most new modern multifocal soft contact lenses are not. So there's only 1 or 2 or 3 on the market that are center distance design. If again you're getting progression with multifocals, then again you need to stop. And some kids may notice that the near is hazy, which they may or may not complain about. But again, it's been proven to be very effective, almost as effective as atropine and autokeratology. So atropine has its side effects, autokeratology might be expensive, so we may be able to fit them with these soft multifocal lenses. Now, like everybody, you can see some people found with no efficiency, while other studies found it was good efficiency, but on the whole, it is doing pretty good. We wear them full time, take them out at night, review every 3 months, and again, when the progression stops, then go back to multifocal, go back to single vision, but you can always leave them on multifocals to give them that reassurance. So when we go through these options and we have our patients in the chair, I think almost ethically now, nobody should be just sitting there thinking, I'll let someone else do it. We should be educating the parents. Now, we need to provide realistic expectations, like anything. And on average, atropine, autokeratology, 50%. And a lot of people get that whole 50%. That we can, on average, stop the progression of the myopic child, depending on, of course, an age and different things, by 50%. Multifocals, maybe 40%, spectacles, maybe 20%. But again, it's better than nothing. Now, you have to let the patients know that, as Dr. Seemongal-Dass said, the result can be highly variable. And it depends on if they are compliant, if they come back if they do what they're meant to do. And the outcomes need to be discussed, because there might be a question here, well, which one do you prefer, Dr. Farnon? And it's not really that easy. Atropine definitely has its thing, autokeratology and multifocal contact lenses. But not everybody's going to fit into those boxes. And so we need to be able to do it. As I said, even if the child is not myopic yet, but the older brother and sister is, that's a start. Get the child outside and away from the devices. So it talks about sitting down with the parents. I know we're all busy. We all have to see hundreds of patients with different things every week. But this is not going to happen in the future. It's already happening now. And I really do believe the responsibility lies with each of us to initiate this conversation about the risks and the reasons for myopia management to the parents. No matter where you are in the eye care industry, someone has to bring it up. If you wait for the parents to bring it up, then that's going to look a little bit funny. You don't want to be the last person to know what the latest, greatest idea is. So Dr. Seemongal-Dass has given you great information, and we've given you information there as well. And a lot of the information from both talks you can take home and use tomorrow. Don't wait until June. Don't wait until September. Don't wait until you qualify. You must know people in your community, even in your family, even in your house, who may be having troubles. Now, every time I give this lecture to the students, they think, oh, if only I was able to do it, because most of you, again, the cart has left the horse. And so think about the people who are coming ahead of you, maybe your younger brothers and sisters or your cousins. And it's great that you're here. It's great that you're listening. And it's great that we're asking questions and having the discussions. So thank you again, Kiyomi. Thank you, TTOSA. And I want you all to have a wonderful evening. Thank you.
Thank you, Dr. Farnon, for that very informative presentation. I would like to ask if anyone has any questions to ask, sir.
Go ahead, Alicia.
Can I ask a question, or actually more of a comment, Niall? Great talk, actually, fairly comprehensive. It's good that we have some of the younger practitioners or beginning practitioners around us as well. It's very interesting because they themselves, a lot of them would be wearing glasses for short-sightedness, right? And they would be of the age that they potentially would have been treated with autokeratology or atropine at some point in time. And it may not have been mentioned to them. So they should think about putting themselves in the boots of the patient to understand what we're saying. I'm sure they do. I mean, we have good students among us. The other thing I am aware of, and you are aware, and I'm aware very strongly, sometimes when you work in a practice where you don't necessarily have full control of the practice, you are driven in a direction sometimes or encouraged that you shouldn't want to go into, right? And I mean, I know that you teach your students the same thing that I do. Professionalism comes first, the patient comes first, and the patient care comes first. And oftentimes, I mean, we've had into the market in Trinidad and Tobago the entrance of stack them high and sell them low. We still see patients, we still see people, and at the end of the day, one of the advantages that we have in Trinidad and Tobago is that we have a small population, but we will meet that population in PriceMart, in the restaurant, in a wedding, and in a temple or in a church. So we have to be aware we are treating people that we'll be seeing for the rest of our lives. So something just to be aware of. Great talk, Lou. Thanks very much.
Thank you. And that's it. You know, that's exactly as Dr. Seemongal-Dass was saying, you know, we all have to work on this together. And as I said, ethically professional, you may not be able to do everything in your practice, but there are plenty of people out there who are able to do it. Definitely the industry work together as we are doing tonight, and let's see how we can help the patients as best as possible. So that's excellent. Anisha, did you have a question, or that was that?
No, sir, sorry, that was the clap in hands.
Oh, there you go. There's me already aging myself. Okay, thank you. Thank you.
If anyone has any questions, you all can present it in the chat and we can ask any of the presenters. Okay, so I assume that the presentation has been very thorough, that there's no questions. Yeah, so we can now close off then. I would like to thank, Dr. Farnon and Dr. Das, both for presenting us with this very informative webinar, presentation, sorry, that has been able to give us more insight on the ways in which we can work together or individually to assist those who may have myopia. So I would like to thank also each and every one of you here today for making the efforts of coming out, and I hope that you would be able to use all the knowledge that you have obtained from this webinar today in in your patient care onwards. So thank you everyone again for tuning out, and I hope you have a great evening and a great week ahead. Thank you.
Thank you, Kiyomi. Thank you, everybody.